Thank you for joining us for the third annual American Association of Kidney Patient Policy Summit, featuring kidney issues capturing time and attention of discussion making. My name is Dan Abel, and I'm a small business owner in West Virginia for over 35 years. I've been dealing with kidney disease for more than 30 years and was on hemodialysis for 19 months before I received a kidney from my sister Mary Beth just a little over 25 years ago. I'm pleased to serve AAKP as Vice President and a member of the Board of Directors. Being a part of the AAKP allows me to represent patients with kidney disease by talking to U.S. senators and representatives on key issues affecting kidney patients. It also allows me to meet and interact with members of other kidney-focused organizations, as well as pharmaceutical and medical technology companies with the potential to help kidney patients in the future. Today, I am pleased to introduce the following panelists. Zachary Cahill, Marketing and Communications Specialist with the American Society of Nephrology Kidney Health Initiative. Tonya Saffer, Head of Government and Market Access for Outset Medical Incorporated. Chris Leibundguth, Director of Federal Government Affairs and Alliance Development for Baxter Healthcare. Peter Maag, Chairman and CEO of CareDx Incorporated. David Davenport, Public Policy Manager for the Personalized Medicine Coalition and Volunteer Legislative Coordinator. These people will be talking to us today on innovations hitting the national radar.
Thank you to the AAKP Policy Summit organizers for giving me the opportunity to talk about the Kidney Health Initiative and how we are meeting this moment and meeting challenges for people with kidney diseases. So in the middle of this pandemic, it's important to remember that once there's little innovation in kidney diseases, but thanks to increased investment from industry and renewed government attention, our community has been given a new opportunity. Today, we face new challenges with a new urgency to capitalize on the environment created last year and deliver innovation for people with kidney disease. I'm Zach Cahill, and I'm on the Research, Discovery, and Innovation team at the American Society of Nephrology. Let's start off by going back in time to 2019 and remembering how much happened in the kidney community over the past year. Most of the past 20 years was categorized by little interest in conducting clinical trials in nephrology. Fortunately, that trend is changing, and industry is investing in new drug trials for rare kidney diseases like IgA nephropathy and hyperoxaluria, and common ones like diabetic kidney disease. Many factors combine to cause this change, including engagement from the patient community and patient-focused drug development meetings, and the establishment of clinical trial endpoints for many kidney diseases. Despite this improving picture, people with kidney disease can expect few treatment options today. While more promising therapies continue to be developed, the pace of change is well behind other disease states, including cancer. Because of the lack of therapies to treat kidney diseases, whether early or late, people who progress to kidney failure have only two options: a rare kidney transplant or dialysis. Despite the fact that dialysis prolongs life for those with kidney failure, this therapy has changed little in more than 50 years and kills half the people who start it in less than 5. The first serious threat to the status quo came in July 2019 with the Advancing American Kidney Health Initiative. This was the first executive order establishing a national strategy for a disease state. This initiative laid out 3 goals for the national kidney policy. First, reduce the risk of kidney failure. Second, improve access to home dialysis. And third, increase access to kidney transplants. For the first time, developing an artificial kidney became the official policy of the United States. Advancing American Kidney Health provided the incentive structure to disrupt the status quo of kidney care for the first time. Advancing American Kidney Health covers everything from organ procurement to payment models. The Kidney Health Initiative identified a handful of priorities highlighted here that hit our sweet spot between pre-competitive and regulatory issues. We'll come back to many of these later. The Kidney Health Initiative is well positioned to respond to the Advancing American Kidney Health Initiative and rally the community together to improve the lives of people with kidney diseases. KEY was founded in 2012 as a public-private partnership between the American Society of Nephrology and the U.S. Food and Drug Administration, committed to catalyzing innovation and the development of safe and effective patient-centered therapies for people living with kidney diseases. KEY is a unique organization in the community focused on pre-competitive collaboration between the FDA, patients, and the broader kidney community. KEY is the largest consortium in the kidney community with over 100 member organizations. Our membership includes patient organizations, government agencies, dialysis providers, medical device companies, pharmaceutical companies, research institutions, and health professional organizations. So we ended 2019 on a high. Things were looking different. For the first time, the federal government had put skin in the game and insisted on change to the status quo. More pharmaceutical companies were investing in testing new molecules in people with kidney diseases, and most importantly, people with kidney disease were believing that things could change. 2020 would provide a significant challenge, but also new opportunities. COVID-19 has changed everything. Not the least of this presentation is recorded from my basement instead of live before an audience. One of the earliest confirmed cases of COVID-19 in the US was a person on dialysis in Seattle. Since that case in early spring, the risk people with kidney disease face during this pandemic has become even more stark. 37 million Americans who have kidney diseases are at increased risk of severe COVID-19 symptoms. Further, the 500,000 Americans on dialysis are exposed to increased risk of infection in transit to and while receiving treatment in dialysis facilities. The kidney is also a target of the virus and can result in kidney failure, increasing the number of individuals now faced with significant kidney disease they did not have before contracting COVID-19. A silver lining is that this pandemic has elevated the profile of kidney disease in the national discussion, with more news outlets highlighting the unique situation of people with kidney failure. We still have a chance to build on the progress of 2019 and deliver innovation despite COVID's unprecedented challenges. The Kidney Health Initiative Board of Directors moved quickly to respond to this crisis and identified 3 areas where KEY could be most effective in protecting people with kidney disease and ensuring that innovation continues during this pandemic. The 3 issues we decided to focus on were advancing home dialysis technology, promoting inclusion of people with kidney diseases in COVID vaccine trials, and ensuring the resiliency of clinical trials through this pandemic. Early in the pandemic, the danger to infection of people getting kidney replacement therapy in-center was a high priority for the American Society of Nephrology. The KEY board recognized that increased adoption of home dialysis could protect people with kidney failure from increased exposure to infection. The board saw the pandemic as a catalyst to accelerate technology development necessary to bring more people home. The position paper we developed outlined a number of technological barriers that need to be overcome, including fluid management, miniaturization technology, self-cannulation technology, water management, and advanced sensors that innovators need to improve to save lives in the next pandemic. Getting more people home, as Advancing Kidney Health intends, is one step to the larger evolution of kidney replacement therapy that is possible today. Providing people with kidney failure more options in the future, from home therapies to an artificial kidney, offer the possibility to decrease the risk of infection and increase the quality of life of people with kidney disease during future pandemics. Another issue that KEY is trying to address is ensuring that patients faced with kidney disease are included in safety and efficacy trials of new COVID vaccines. It has been shown with other vaccines that those with reduced kidney function require different vaccine administration strategies, such as dose and frequency. Trials can help determine if different strategies are needed for kidney patients at risk for coronavirus infection to ensure that they are protected. With the increase of development in the nephrology pipeline and the impact COVID-19 was having on the conduct of trials, we knew that we had to assist the community with ensuring that these trials continued to provide both hope to people living with kidney diseases and continue the investment in the nephrology pipeline. On July 15th, KHI hosted a town hall with various industry and patient organization stakeholders to discuss the various approaches to continuing trials during a global pandemic and the lessons that were learned. This town hall also highlighted patient-centered approaches to bringing trials to people living with kidney diseases. None of these initiatives would be as effective as they are without the patient perspective. And I would be remiss to talk at an AAKP event without spending time on the importance of people with kidney disease in drug and device development, starting with making sure that we design new options that focus on improving the lives of people with kidney disease. Key embeds the experience of people with kidney disease into our work through the Patient and Family Partnership Council. They are charged with ensuring that the patient perspective is first and foremost in drug and device development. Members of the PFPC serve on our board of directors and on many of our work groups. The key PFPC has had a significant impact over the past few years. An early example of their effectiveness was in informing the FDA's decision to change care partner requirements of the next stage home dialysis machine. Today, the PFPC is still busy elevating the profile of kidney disease and the patient perspective. Two highlights of their work this year are a comment letter to the FDA's Office of Minority Health and Health Equity, encouraging them to include kidney diseases as a key priority area, as kidney diseases represent one of many health disparities facing the minority community, and comments on the Medical Device Innovation Consortium white paper on including the patient perspective in device development. These efforts helped to raise the profile of kidney diseases beyond the kidney community. A prime example of how KEY includes the patient perspective in device development and encourages collaboration across the kidney community is our technology roadmap for innovative approaches to renal replacement therapy. The genesis of this project was the 2016 White House Organ Summit, where KEY committed to developing a roadmap describing how to achieve the next generation of kidney replacement therapy. The roadmap was created by a diverse group of subject matter experts, including government representatives, people with kidney diseases, researchers, and innovators, to name a few. The roadmap was intended to be a living document, and the first edition came out in 2018, and updated versions are in the works now. The primary objective of the roadmap was to increase interest, investment, and innovation in kidney diseases. It begins with patient preferences and ensures that each solution it describes achieves a goal that people with kidney diseases have prioritized. It provides both existing innovators and new entrants into the field a clear idea of what the scientific and engineering obstacles are that need to be overcome to develop novel kidney replacement therapy. The roadmap is solution agnostic, meaning it does not prioritize one potential alternative to dialysis over another, but describes the path of cellular, engineered, and hybrid technologies that are both portable, wearable, and implantable. It also predicts time horizons for when innovations can be achieved to help innovators divide their efforts between short and long-term goals. As I mentioned earlier, the RRT roadmap is a living document, and KHI continues to produce companion resources and additional versions. Advancing American Kidney Health also provided additional motivation to build on the roadmap. After all, KEY provided the roadmap to develop an artificial kidney, and that artificial kidney is now a national priority. KEY's Fluid Management Report takes one technology area of high priority to people with kidney disease and provides extra detail for interested innovators. KEY also developed a patient edition of the RRT roadmap to help people with kidney disease and their providers understand what the future of kidney replacement therapy looks like in both the near and long term. KEY is currently working on two projects connected to the roadmap and Advancing American Kidney Health. The first project, a priority of the FDA, will describe what a clinical trial for an artificial kidney will look like and attempts to define what we mean by artificial kidney. This information will help regulators assess both the safety and efficacy of new artificial kidney candidates. The second project is our Patient Preference Initiative, funded by an FDA grant and specifically called out in Advancing American Kidney Health. This project will help place scientific rigor behind the inclusion of patient preferences and regulatory evaluation of novel kidney devices. So how does all this fit together? At ASN's Research, Innovation, and Discovery Center, we think about the problems facing the kidney community from the bench researcher all the way to the commercialization of a new therapy. We are partnered with government agencies and the kidney community at every step of the way. All this work happens in the context of Advancing American Kidney Health, and its call to change the status quo of kidney diseases. So those involved in the kidney community have always known the situation of people with kidney failure. People with kidney failure are often in underserved communities and minorities. The COVID-19 pandemic has only served to highlight the disadvantages many people in the kidney community experience every day. This quote reminds me of why it's important to improve the lives of people with kidney disease, even during a pandemic and racial unrest. People with kidney diseases have waited long enough for innovation, and the kidney community stands ready with the tools and resources they need to deliver the innovations that people with kidney disease deserve. Thanks for listening, and if you're interested in learning more about the work of KHI, you can visit our website, kidneyhealthinitiative.org, or contact us at khi@asn-online.org. Thank you.
We'd like to thank Zachary Cahill for his presentation today, and we'd like to introduce Tonya Saffer.
Hello, and thank you, AAKP, for the opportunity to share my perspective on how we can utilize technology to transform kidney care. And rather than simply call out the status quo, call in other stakeholders to lead that transformation. I'm Tonya Saffer, Head of Government Affairs and Market Access for Outset Medical. A few of you may know me as I have worked with you and been an advocate for kidney patients in a few different roles over the past 14 plus years. What drove me to Outset last summer was a strong desire to be on the ground level and in the trenches to build a better kidney care experience for patients. Outset Medical is delivering first of its kind technology into the growing dialysis market with a goal of reducing the cost and complexity of dialysis and transforming the patient experience. That's our standard line, but let me give you the next layer of who Outset is. The period in front of the O in Outset's logo signals the start of a new sentence, a new chapter, highlighting a new and better beginning for kidney patients needing renal replacement therapy. Outset lives up to its logo and its name by continuing to innovate to improve kidney care for patients. Outset's Tableau hemodialysis system simplifies and automates much of the dialysis process, empowering patients to engage in self-care dialysis and freeing healthcare providers from the workflow challenges and infrastructure requirements that surround conventional dialysis treatments. If there is one thing I have learned from my friendships with patients, it's that their transition to end-stage renal disease sucks. It's literally awful, heartbreaking, and hard to bounce back from. My friends and I in the policy world always talk about and read about the problems of fragmentation in healthcare. There is probably no better example of the reality of this than kidney care. Patients often start in-center chronic dialysis, having crashed into the hospital, not knowing they even had underlying chronic kidney disease, and with little to no nephrology care prior. They are unaware of their opportunities to get a kidney transplant or to start home dialysis. There are many ways this problem needs to be solved, and ideally it starts with prevention and then awareness. However, technology can also enable a better transition that leads to empowerment of patients to engage in self-dialysis, whether that be at home or in a self-care clinic, the likes of which rarely exist today. So let me tell you a little bit more about Tableau and how Outset offers the solution before I jump into the questions and the sorely needed policy and healthcare changes. So this is Tableau. All it takes is an electrical outlet, plug it in, hook it up to a standard water tap, like your faucet or bathtub, and drain it into the tub or toilet, and you have dialysis on demand. No waiting to batch bags, no shipments of heavy bags to store, no bags to warm and hang, and no snapping of tapping of lines and tubing. Turn on Tableau and it's ready to go anywhere, anytime, by anyone. Tableau was designed for patient self-care from the outset, and on March 31st, the vision became a reality when Tableau was approved for use in the home. You can see it's at the height of Tracy here, turned towards her, allowing her to glance over and monitor her treatment while she happily scrolls through social media on her phone. When it is not in use, it's easily wheeled to a closet or inconspicuously closed up and moved off to the side, no longer looking like a piece of medical equipment. Let me talk a little bit about what Tableau has meant to Tracy. Tracy had a kidney transplant that sadly, after 7 years, failed. Her nephrologist encouraged her to try home dialysis and introduced her to Tableau. Tracy had tried home dialysis on another device prior to her transplant, but the experience had not been a positive one. She had multiple challenges and hospitalizations, and ultimately, after 3 months, returned to in-center dialysis. Despite her previous experience, Tracy wanted the freedom that home dialysis provides, and with COVID, she felt safer being at home. Tracy is at home as of early June with her Tableau, which she calls Tammy, and is happy and doing well. In fact, I talked to Tracy this past Sunday, and she feels great and has a ton of ideas for how to engage in advocacy, particularly living donor advocacy, as her son was her previous kidney donor. I was there with several of you when the President of the United States took the stage and declared that kidney health was a public health priority. To be honest, while I was a long time and I am a long time patient advocate, this was always a goal I had worked towards. I have to admit, I was shocked but elated that the day had arrived. The goals are laudable. They are ambitious, serving as our kidney moonshot. They are everything all of us have been advocating for years. Progress has been made for sure. However, when it comes to end-stage kidney care and moving away from the traditional dialysis model, there's still a lot of work that needs to be done by our policymakers to remove the barriers that stand in the way of innovative care delivery. We really need a change to the conditions for coverage that regulate what is and who can be a dialysis facility. So building upon that, for example, imagine nurses transformed into coaches and PCTs transformed into cannulation teachers. What if instead of going to a clinic with 25 other people, you could receive your dialysis in your physician's office or within the health system where you already receive your other primary care services? If you had an urgent need for dialysis due to fluid overload or another acute episode, you could swing by the nearest urgent care center and get your dialysis. What if you want to do your own dialysis, but simply don't want it to be in your home? Is there a small neighborhood self-care clinic nearby where you could go and safely be monitored remotely by nearby clinicians? What if the 40% of patients who crash into ESRD could start training for home dialysis right there in the hospital? So I'd say, number one, we need to change the conditions for coverage. Number two, we need to embrace innovation, and Medicare needs to embrace innovation. And there have been some great strides in this already. On July 6th, the Centers for Medicare and Medicaid Services issued its annual proposed rule on the ESRD prospective payment system. The ESRD PPS annual rule, as many of you may know, updates the per treatment bundled payment amount and payment policies for outpatient dialysis facilities receiving reimbursement under Medicare Part B. Last year, CMS created a new a transitional add-on payment adjuster for new and innovative equipment and supplies called TPNIES. And it's intended to encourage dialysis facilities to adopt new technology that represents a significant substantial clinical improvement for patients. This payment adjuster is an additional payment to the per treatment reimbursement bundle that outpatient dialysis facilities receive, and would offset a portion of the facility's costs for purchasing new technology. Unfortunately, last year's final rule stated that capital-related assets, which meant dialysis machines purchased by the facility, were not eligible for the add-on payment. However, this year on the 6th of July, CMS is proposing to allow capital-related home dialysis machines to qualify for TPNIES beginning in application year 2021. If finalized, this rule would accomplish several goals and provide promising opportunities for patients to have access to new technology. It would create an incentive for dialysis facilities to purchase this innovative new dialysis machines for use in the home that have evidence that they can provide patients with substantial clinical improvement over the existing technology. The add-on payment would provide greater opportunities for patients to do their dialysis at home. Second, allowing dialysis machines to qualify for TPNIES creates an incentive for manufacturers to develop even better devices in the future that make it easier for patients to do their treatment at home. This is not a policy created to only benefit one type of machine or even one company, but would prove to manufacturers and investors that indeed there is a pathway to getting new innovative renal replacement devices to patients. For so long, there have been the haves and have-nots in healthcare technology, and kidney patients have often been in the have-not category, as innovation in renal care has been stagnant for decades, while innovation in other medical device specialties like cardiology has boomed. This has been largely due to a lack of investment in the renal field. Success begets success, and if innovators in home dialysis see that there is an opportunity for both reimbursement and provider adoption, we can expect to see even more access for patients to new technology and continuous innovation. It's no secret that Outset hopes to apply for Tablo to receive reimbursement under this proposed pathway, as it will be up to dialysis providers to ensure that patients wanting the choice to use Tablo at home will have it. With a favorable final rule from CMS on TPNIES, including home dialysis machines, we know that Tablo won't be the last innovation in the near term, making it easier for patients to receive renal replacement care at home. And that's the way it should be. Technology isn't the only area for innovation. We also need to see innovation in kidney care delivery, which is currently trapped in a sea of outdated regulations and payment constructs. Modernizing the concept of a dialysis facility and an interdisciplinary care team more broadly, and particularly in light of the availability of new technology that doesn't require the need for a clinic to be built around a water treatment room, is also needed to improve patients' experience with care. So who do I believe will drive such a transformation? Will it be these current castes of providers? Will it be commercial payers now responsible for more dialysis patients than ever before? Because patients beginning in 2021 will be able to enroll in Medicare Advantage plans for the first time without restrictions. Will it be new kidney care companies backed by venture capital arms of those commercial insurance companies who are desperately looking for lower cost ways to provide better quality of care to patients? Will it be hospitals and health systems who grapple with the costs of delivering uncompensated inpatient dialysis care when patients get sick and are hospitalized? Or will it be our trusted nephrologists who take the reins and reimagine the dialysis clinic and patient experience? So here's what I think. I think we are all frustrated with the state of care today. We want a world where dialysis isn't necessary. We want prevention first and transplants for everyone who does experience kidney failure. That's the future we all imagine together. But instead of calling out people for the lack of innovation, let's call those others in. Innovation, in my experience, often comes from external forces that see a gap or a new opportunity. But I think it's clear that there are multiple stakeholders that, while driven by cost, profit, a drive to do better for patients, innovation is going to come in many shapes and forms. So rather than call out those dialysis organizations for lack of speedy transformation, let's call these others in. Bringing in our health systems, hospitals, commercial payers will only add to the brain power and healthcare expertise within the field of dialysis, creating more innovative care delivery that can improve patient experience, connect our fragmented systems, ease transitions, improve outcomes, and lower healthcare costs. Nurses, doctors, patient care technicians can all help transformation in care by allowing patients to begin learning how to deliver their own dialysis from day one, by empowering them to first start participating in small aspects of their dialysis care, growing that each day or each week to encourage them to unlearn any helplessness they may feel and show them that they can have as much control over their care as they desire. However, little will truly change if we have new entrants who ultimately have to build the exact same care model and infrastructure because of outdated regulations known as the conditions for coverage. It's time to improve quality by revisiting these requirements of what it takes to be a certified outpatient dialysis facility. So we can imagine a new world of kidney care. And before I answer the questions that have been thoughtfully provided to me, I'm calling all of you in. I want you all to act now along with us to improve kidney care today. Patients, providers, tell your story. What are you doing to innovate? How have you managed living on dialysis? And what does having the latest technology and home dialysis mean to you? I challenge you to redesign the dialysis care experience and talk to our friends at the Centers for Medicare and Medicaid Services and at the U.S. Department of Health and Human Services about what that experience should look like from a patient's point of view. Maybe I just created the next redesigned dialysis, Kidney X Prize, ASN and HHS, I'm now calling you into. Can you reach out to your lawmakers and demand for change that will impact your lives today? Patients, those of you watching may be among the most activated and engaged. Can you call others in? Can you reach beyond your current social networks to engage with those who are in great depths of despair with the current state of in-center dialysis? Current home dialysis patients, are you in those social media forums of your in-center peers talking to them about self-care and home alternatives to help educate them and show them that there are other options, that the future could be brighter? Policymakers and regulatory friends, you wield significant power to change and immense responsibility to protect. Don't let the fear of what ifs drive you to be stalled in your actions. The very scary what ifs are happening too often now, particularly with COVID. Nephrologists, health care and hospital care clinicians, administrators, don't throw your hands up exasperated that we can't realize change, that it's too hard, too expensive, and the barriers too numerous. You can innovate and advocate at the same time. Look to your peers who are adopting and innovating in the VA, in hospitals, and in reimagined outpatient kidney care delivery. Payers, connect with those innovators. When you do, you will see more innovators follow. Quality will improve and costs will go down. I am forever an optimist that together we will build a new nation of kidney care with more choices and improved outcomes for patients. Better begins now. So here's how you can stay in touch with Outset and our policy and advocacy work. I encourage you all to join us. Thank you so much for the time today, and I look forward to responding to the questions from the moderator.
Thank you, Tonya Saffer, for your presentation. And now I'd like to introduce Chris Leibundguth.
Hello, my name is Chris Leibundguth, and I lead government affairs for Baxter's renal business. Today, I'll be presenting on the need for balanced evidence requirements in TPNIES, which is a new policy from CMS that provides an additional payment for new innovative medical devices for patients with kidney failure. So I'll start by giving some background on TPNIES. TPNIES stands for the Transitional Add-on Payment Adjustment for New Innovative Equipments and Supplies. And yes, that is a mouthful. TPNIES was created by CMS in their annual payment rule. The rationale for creating TPNIES is simple. Prior to the creation of TPNIES, the Medicare bundled rate for ESRD was inadequate to cover the costs of new medical devices. So from a practical standpoint, a company like Baxter could develop a new medical device for patients with kidney failure, get it approved by FDA, and bring it to market. But without any additional reimbursement, that new device would never reach the hands of patients in a meaningful way. And this reality contributed to the lack of innovation available to patients over the last several decades. Baxter's been advocating for a policy such as this for about 2 years, arguing that similar policies exist for drugs and devices in the inpatient and outpatient payment systems and for drugs in the ESRD bundle, but not for ESRD devices. Maybe more importantly, Baxter pursued this policy because we have a new innovative dialyzer that is available in over 40 countries, and we want to bring it to the United States. That dialyzer will hopefully be cleared by FDA in the next few weeks, and we are one of 2 devices that have applied for TPNIES in this year's ESRD payment rule. But TPNIES is new, and like most new policies, it needs some refinement. The most important area where that refinement is needed is in the process by which CMS evaluates which device should receive the add-on payment from TPNIES and which devices are adequately covered by the existing bundled rate. TPNIES uses a standard called Significant Clinical Improvement, or SCI, to evaluate a device submitted for TPNIES. SCI is a list of criteria by which CMS judges the evidence presented by the manufacturer to determine if the new device is significantly better than an existing product. So SCI is basically a list of questions. So does the device perform better? Are the outcomes of the device better? Are the quality of life improvements or patient report outcomes better than a existing product? Ultimately, CMS reviews that evidence and grades it against the SCI standard, and then makes a judgment call about whether that product, the new one, meets the significant clinical improvement standard. What's not been clear, however, is what level of device is sufficient for CMS. Over the last two payment rules, CMS has commented on the value of a wide variety of evidence, including small trials and diverse real-world evidence. But in the most recent rule, CMS seemed to comment that they wanted to rely on large, blinded, multi-center clinical trials. From the viewpoint of a manufacturer, the level of evidence really hasn't been well defined. However, the program is up and running, and we at Baxter are being evaluated, or our product is being evaluated as we speak. So that begs the question, why would making a large randomized controlled trial the standard be problematic? So there's actually multiple reasons. First, historically, conducting large randomized controlled trials has been difficult for kidney disease patients. The reason why is disease burden is very high, as you know, which impacts recruitment and dropout. This is somewhat specific for devices. To give you an example, it's easier to ask a patient to take a pill or do an injection than it is to ask them to try out a new medical device. Secondly, randomized controlled trials are very expensive and take a very long time to conduct. A randomized controlled trial of the type that CMS is referring to can span 5, 6, 7 years and cost hundreds of millions of dollars. Meanwhile, smaller trials can be conducted in the course of 5, 6, 7 months. Therefore, you can conduct several smaller trials at the same time and produce a wealth of information and evidence. For devices that are on market in other countries, you can also present evaluations of real-world evidence, which oftentimes does a better job of capturing patient-reported outcomes and opinions about the therapy from patients. And if you combine smaller studies or several smaller studies with real-world evidence, you can produce a significant level of evidence in a shorter time period for far less the cost. However, the last point is probably the most important. Virtually all medical devices that treat kidney disease and kidney failure, and all emerging devices and most contemplated future devices do not or will not require a randomized controlled trial to be approved or cleared by FDA. So if FDA only requires a lower level of evidence to get through and CMS requires an RTC, you might have a situation where lots and lots of products, lots of medical devices that are coming through can get cleared through the FDA, but they cannot gain reimbursement. So why does this matter? If CMS implements these over-restrictive evidentiary requirements, the net impact will be this. You'll have new innovations being cleared by FDA, and they'll be cleared using a 510K process or de novo process. However, when that product gets to CMS, if they require a large randomized controlled trial, then they'll be denied TPNIES. This would essentially maintain the status quo. This is a problem even further exacerbated because there are now several current efforts to drive innovation in the ESRD space. TPNIES, the President's initiative on kidney health, and KEY, just to name a few, have in recent years driven the desire to have more products available. It's driven manufacturers to go further and further in terms of the types of innovations they're going to put into the market. But if there isn't any reimbursement for those innovations, then they will not reach the hands of patients. And therefore, we hope that as we go through the rest of this year, as TPNIES becomes more refined, that CMS will hear from patients, they'll hear from clinicians, that while they want a well-structured pathway, one that does imply a discerning eye in terms of what kinds of products are put on market, that they keep it balanced and make sure that those products that can produce a wide variety of evidence are well considered for substantial clinical improvement and then put on market and provide the reimbursement. Thank you so much. Thank you to AAKP for inviting me to give this talk. Thank you.
Thank you for that presentation, Chris, and we'd like to move on now to Peter Maag.
Welcome to the third AAKP Policy Summit. My name is Peter Maag. I am the CEO here at CareDx. I welcome you to the session. Thank you so much for being with me. What a difference a year makes. I remember very well the second AAKP Summit and being all with you in one room. Now, in these times, we need to do with a virtual reality. Nevertheless, I'm looking very much forward to talking to you. We at CareDx focus on transplantation patients. Here on this slide, you see not only the transplant recipient, but also the organ donor as well as the primary caregiver. We at CareDx focus on the entire transplant ecosystem, and kidney transplant patients are a lot of transplant patients. So really end-stage renal disease very often are leading to kidney transplantation. This is when the CareDx story comes in. I focus on transplantation patients every day, and I'm looking very much forward for continuously doing so. As a CEO, you might see here at the Policy Summit that there are not many CEOs right now working in transplantation. Actually, there are not too many CEOs working in kidney health. I'm looking very much forward on continuously driving innovation. What's next? What's new? Not only in kidney health, but also in transplantation. At CareDx, we focus on the entire transplant continuum, all the way from pre-transplantation to post-transplant care. With our products, services, and solutions, we focus on the transplantation patient, and we're driving innovation, not only on the waitlist management, also on organ recipient matching, as well as providing liquid biopsy tests. AlloSure is really the latest innovation in that space. And we also provide augmented intelligence solutions. We do offer electronic medical systems with many transplant centers in the country, as well as helping them to manage their quality with our quality management solutions. In the space, CareDx is really driving innovation. We not only brought the first donor-derived cell-free DNA technology in transplantation to the transplant community, we also brought the first target capture sequencing technology that's helpful in the matching of organs and recipients to the transplant village. As well as now we're innovating on augmented intelligence in transplantation care, which is the latest innovation in transplantation as we're thinking about digital solutions. Now, in my talk, I would like to focus on how do we drive better outcomes, how can we improve surveillance of these transplant patients, and then how can we engage the transplant community and more specifically the transplant patient. Let's first focus on better outcomes. It is so incredibly important that we focus on our products and solutions. How can they drive long-term outcomes by measuring long-term graft survival? We at CareDx do that by focusing on how can we improve immune modulation, how can we improve compliance and adherence, and how can we personalize approaches by standardization and driving individualization strategies to really make sure that we can focus on the individual patients. We here at CareDx focus on wanting to improve graft outcomes by 3 years. Wouldn't it be great if we can have these organs last for 3 years longer than the current long-term outcome, which is about 10 years? Now, on our surveillance solutions with AlloSure and AlloMap, we follow the transplantation throughout their transplant patient journey. Our solutions focus on being less accurate in diagnosis of active rejection versus more accurate in diagnosis of active rejection. You see that AlloSure is really driving a more accurate diagnosis of active rejection, but at the same time being non-invasive. So AlloSure is a blood-based diagnostic testing service that provides non-invasive and accurate rejection surveillance. And we have taken this with RemoTrack to the really next level, where we are providing home-based phlebotomy. So there is a phlebotomist coming in your home, does the blood draw, and we at CareDx make sure that the results are coming back to the transplant center or your caregiver. That's a true innovation in terms of service level, because you can imagine that these are very complex logistics that we need to figure out. Now let me focus on how can we drive engagement, which is a very important area of innovation in the healthcare space. With AlloCare, we have a patient support network figured out. We are not only focusing on waitlist management or maybe one day making Tracy, this is the Alexa for transplant care, available in the future. Right now, we're really innovating in the space with driving a transplant patient app. How are we going to do that? We're going to do that with our patient app that helps to remember appointments, that helps patients to track and monitor medication adherence, that helps with measuring health activities, and maybe helps by building a transplant community, all with the help of a simple transplant iPhone app. Now, if you want to hear more about it, join us at the AAKP Transplant Festival on September 26th at 2020. We are now accepting invitations at caredx.com/transplant festival. Come and join us. But we're not only launching these innovations that are patient-focused, we are also focusing on providing our solutions for doctors. Now with our iTrack, we're providing insights to transplant care for the transplant physician. We're focusing on how can we change the prognosis, how can we make care recommendations more tangible for doctors, and then maybe we can support them in maybe thinking about medication recommendations. Very dear to my heart is maybe optimizing immune suppressive therapy, maybe reducing some of the drugs, of the many drugs that transplantation patients need to take after transplantation. Now we focused on surveillance and engagement to drive better outcomes. But let me touch base also on transplant policy changes that we're driving forward. It's not only innovations that are counting, it's also the changes in policy that are very important here at CareDx for us. In 2018, with our leader policy, we made sure that every employee at CareDx is having no negative implications when they sign up to become a donor or if they are actually providing organs. This has been very, very well received as we are trying to be an employer that's very responsible in the space. Wouldn't it be great if other employers are following suit and making sure that their employees, when they become an organ donor, they have no negative consequences? But we have not only focused on the leader policy, we also take it a step further. We are a proud sponsor of the Honor the Gift campaign. It is a grassroots campaign supporting that immune suppressive medication payments by Medicare is extended beyond the 3 years. That has been an incredibly rewarding policy that we have helped to continue to push. It has been tried many, many times, so CareDx is not alone in that battle, but the transplant community and the kidney community has really come together. Together with many organizations, we have been incredibly supportive and active on the Hill, really supporting this immuno bill, it's called, and moving this forward. Together with our friends from AAKP, which have had this as a long-lasting policy, we've been helping to move this now to the next level. And what a difference it had made. In 2020, we are very close of making the immuno bill a reality. Please join me in honorthegift.org campaign, sign up and let your congressman know that you'd like to have this bill move forward. You have probably heard about it many times. Now is the time to action. Well, thank you very much for your attention. I'm so glad to be here at the third AAKP Policy Summit. Thank you very much for providing that platform. And I'm very much looking forward to soon see you again in person. Thank you very much now.
Thank you, Peter Maag, for your presentation. Now we'd like to introduce Dave Davenport for his presentation.
Hi, everyone. My name is David Davenport from the Personalized Medicine Coalition. I'm the Manager of Public Policy and Secretary to the Board at the organization, and I really appreciate AAKP for inviting us to participate in their third annual policy summit. PMC is a coalition of over 200 organizations spanning the healthcare spectrum to advocate for personalized medicine. This includes patient advocacy organizations such as AAKP, who represent cancers, rare diseases, and health disparities, research and clinical care institutions, both in the community and the academic setting, pharmaceutical and diagnostic companies, a payer, IT informatics companies, venture capitalists, and a number of other strategic partners. With my presentation today, I'd like to provide some background on personalized medicine, share some activities that PMC is leading to advance personalized medicine for patients, and highlight some key opportunities along these lines for improving the delivery of personalized medicine. So just as a little bit of background, PMC defines personalized medicine as an evolving field in which physicians use diagnostic tests to determine which medical treatments will work best for each patient. By combining the data from those tests with an individual's medical history, circumstances, and values, healthcare providers can develop targeted treatment and prevention plans. Personalized medicine can benefit patients by shifting the emphasis in medicine from reaction to prevention, reducing trial and error prescribing, reducing adverse drug reactions, revealing additional uses for medicines, increasing patient adherence to treatment, reducing high-risk invasive testing procedures, and finally, helping to control the overall cost of healthcare. In the case of kidney disease, a test many of you are probably familiar with is AlloMap. AlloMap is a multi-gene expression test that detects whether the immune system of a transplant recipient is rejecting the new kidney. AlloMap was one of the first examples outside of oncology where a biomarker test informed transplant care. Over the past few years, these tests have grown in their complexity to measure the likelihood of organ rejection. As research in kidney disease, such as through the Kidney Precision Medicine Project, look at biological and genetic markers that may be underpinning the onset of kidney disease, personalized medicine presents opportunities to develop treatments targeting those biological pathways. Thanks in part to an intentionally supportive regulatory environment in the United States, personalized medicine is a rapidly evolving field. For each of the past 5 years, personalized medicines have accounted for a quarter or more of new drugs approved by FDA, with a record of 42% in 2018. In 2005, personalized medicines accounted for only 5% of new drug approvals. The most recent approvals address the root causes of rare diseases and many patients for whom there were no options before, including those diagnosed with spinal muscular atrophy, Duchenne muscular dystrophy, cystic fibrosis, and sickle cell disease. And what we've also seen over the past decade is a growing number of personalized medicines being available to patients outside of oncology. Personalized medicine presents opportunities to understand how differences in an individual's biology affect his or her health, so that prevention strategies and treatments are guided to those who will benefit. However, there are fundamental gaps in awareness and access that impact the speed at which personalized medicine products and services are integrated into healthcare. The healthcare system has made incremental progress in advancing personalized medicine, but we must continue to do so in order for the health system to fully consider the individuality of patients' health needs. This uptick in personalized medicines coming to market has challenged the healthcare system in terms of how new treatments are regulated, covered, and reimbursed by health insurance, as well as integrated into the clinical setting. PMC is working on all of these fronts to make sure that the health system moves from a one-size-fits-all approach to one that considers a patient's individual variability. And in particular, for the rest of my presentation, I'd like to focus on one of PMC's initiatives to better understand patients' priorities for improving their healthcare when it comes to personalized medicine. A little over 2 years ago, PMC received a 2-year engagement award from the Patient-Centered Outcomes Research Institute to convene patients as well as healthcare providers and other key stakeholders to develop a research agenda that looks at patients' priorities for improving the delivery of personalized medicine and how to change healthcare in a way that is most meaningful to them. Some of the lessons that we had from our discussions over the past 2 years with patients include that healthcare professionals must listen to their patients and have more nuanced conversations. But they're also facing their own barriers as well when it comes to having adequate resources and technologies to interpret and provide treatment options that are based on a patient's genetic information. Patients indicated that considering their values and circumstances in the treatment decision-making process was just as important as considering their biology. They want family and caregiver considerations, financial concerns, as well as reservations about participating in clinical research to be a part of that conversation as well. Patients want to be educated over a period of time and not just at diagnosis. And given the diagnosis shock that many patients experience when they learn that they now have a disease or condition, many patients express preferences for being educated about the benefits of personalized medicine prior to their diagnosis. When it comes to access and affordability considerations, one of the questions that could use further research is, how do a patient's needs and access barriers, including those related to cost and affordability, change depending on the purpose of the genetic test? For example, a test to identify a patient's risk of developing a disease versus a test to identify an appropriate treatment option for that patient. The patients who participated in these discussions really spanned an array of disease areas and backgrounds, as well as health needs. And one of the concerns that was brought to us by many of our minority patients participating in the project was the historical mistrust of medical research, in particular patient populations. And in order to advance personalized medicine, clinical trials must not only increase diversity, but really focus on building trust with patient participants. Another way through doing this is by increasing transparency for patients when it comes to the information that is being collected from them and how that is being used. Finally, we also did talk about changes that need to happen to the healthcare system writ large in order to improve personalized medicine delivery. And when it comes to updating billing and reimbursement structures, both patients and providers indicated that changes are needed in order to facilitate them educating patients about person treatment options, especially if multiple sessions are required to discuss options and educate them. So overall, to improve patient outcomes with personalized medicine, the healthcare community must shift away from a one-size-fits-all paradigm to a system centered around a patient's unique needs and priorities. The health system, including billing and reimbursement structures and data systems, must improve to create opportunities for continued patient education about genomics and personalized treatment options in varying healthcare settings. Professionals and researchers must also focus on being transparent and building trust to address biases and inequities facing minority populations. And we'll be coming out with a white paper later this summer that outlines the research agenda as well as the project. And we look forward to sharing that with you. Thank you to AAKP for inviting us to participate, and I'm happy to answer any questions.
Thank you, Dave Davenport, for your presentation on today's innovation hitting the national radar. Okay, we also have a few questions today. So for Zachary Cahill, here's the first question. The Kidney Health Initiative has become the largest conveyor and center for innovation strategies across the entire kidney community, and AAKP is quite proud of the fact we are pioneer members of the KHI. Can you tell us how having patients and patient groups like AAKP represented on the board and on the Patient Family Partnership Council makes an impact on a practical basis in your work?
Yeah, so having the patient perspective is obviously essential to everything KHI does. We've included it in our organizational structure. As I talked about, we have patient perspective on our work groups and at our board. The difference that makes is it keeps us grounded. It gives us the motivation to kind of keep on pushing on issues that patients have prioritized. It also points out issues that we overlook. Key is a large organization, and we hear from people as diverse as academic researchers to medical device developers and the patient community. And the most important voice there is the voice of the patient. And we need to make sure that we hear that and prioritize that in all of our projects. So one thing that stood out to me when we were developing our home dialysis position paper was that the situation of people with kidney disease during the COVID-19 pandemic, and just the fear that they have going into dialysis clinics. And that really motivated how we produced that entire document. And we wouldn't have been able to see so clearly the situation that people with kidney disease were in now, and the benefits that being on a home therapy were if we didn't have a patient involved in the writing of that document. So the patient perspective is essential to everything we do and influences everything that we produce at KHI.
Okay, we have another question. As a professional in the kidney policy and innovation space, can you tell us what impact the relationships you have with kidney patients and their stories have had on you and your drive to achieve KHI goals?
Well, frankly, it's motivating. So the more time I've spent in the kidney community, and the more time I've gotten to know people with different kinds of kidney diseases on different modalities, it really motivates me to do the work I do well. I think it's also given me a greater sense of urgency to get the work done that we've set out to do. Primarily, when you think about many people on dialysis die. That has changed how I talk in our messaging, how I write content for KHI, just imparting the urgency that we have to change this field, and the fact that many of the people that we work with won't see the benefits of the technologies that we are developing today. I always think back on the story of a kid named Cahill who spoke at the 2018 KHI annual stakeholders meeting, just describing how the excitement he has thinking about the artificial kidney and the hope that it brings him as someone who does not have any more access sites and who can't receive a transplant, to just think that people are developing an artificial kidney that he might benefit from. So it's motivating. It helps get through a lot of the obstacles that we have in pushing innovation forward. And I'm really thankful for the relationships with people with kidney disease I've been able to develop over the more than 5 years I've been involved in the kidney community.
Okay, Chris Leibundguth, we have a couple questions for you. AAKP believes government can impact the trajectory of kidney medicine, but that the onus for continued long-term and positive rest with the kidney community. Can you tell us how you view the role of advocacy organizations like AAKP in advancing the principles of care, choice, and greater innovation?
I think that patient advocacy organizations like AAKP are essential. We are living through exciting times in the kidney space. For so long, innovation has been stagnant. The payment system has been, created in a way that was necessary at the time. I think that especially in recent years, it has done more to constrain possible innovation. And it's one thing for a manufacturer to stand up and say, hey, this needs to change. It's one thing for clinicians to stand up and say, this needs to change. But it won't really actually change unless patient advocacy organizations come to the table and talk about the real problem, right? Because it's not necessarily about the drug company or the medical device company. It's about the patient. The patient looks around themselves and they see people who have other complex diseases like cancer or sort of neurological problems, and they see therapy after therapy being approved, and those spaces providing a real hope to patients. And then they look at the end-stage renal disease space, and the technology that we use is more or less the same. It's been the same for decades, and with no really big radical change. And therefore, the voice that really matters here, the one that's actually going to make things change, is going to be the patient. It's the patient voice that needs to be sort of step forward and talk about all of these aspects, not just the lack of innovation, but even, I would say, the manner in which the government controls and implements the reimbursement process. Because if there's problems in the reimbursement process that constrain the ability of innovative devices or drugs getting to patients, then it's the patient voice that's going to change that. It's not going to be ours. It's going to be yours.
Okay, we have another question for you. As a professional in the kidney policy and innovation space, representing one of the largest global healthcare companies in the kidney space, can you tell us what impact the relationships you have with kidney patients and their stories have had on you and the desire to push for new treatments?
So I have an interesting story. I started at Baxter about a little over 2 years ago. When I did, I didn't really know many people personally who suffered from kidney disease or kidney failure. But that changed. When maybe about a year into my job, I had a family member contact me and let me know that their father-in-law actually was about to go on dialysis, and he was in his, I think he was in his early 80s, and he didn't know what his options were. He knew his options were. He thought that he would go in-center dialysis, and he didn't want to, and he wanted to go and do palliative care. And I talked to him about the variety of different options available besides just in-center hemodialysis. And he had never heard of any of it. He'd only ever heard of in-center hemodialysis, didn't know anything about home dialysis. And so I gave him a bunch of resources to take a look at. I told him about AAKP. I gave him some other literature he could read, so it wasn't just reading like Baxter stuff. And I told him there's all these other options, right? There's peritoneal dialysis, there's home hemo, and I told him a little bit about some of the possible innovations that are on the horizon. And he literally went from a viewpoint that he didn't want to live anymore. He didn't want to go through dialysis. He was just, I'm not going to do this, to a level of hope that he could live with it, that he could maybe do dialysis at home, and that there were these things to look for in his life. There was a possibility that the space could change. And that experience really has motivated me more than anything else. His personal experiences drive you probably the most. But to be able to have that conversation with him, to talk to him about it, it meant a lot to me. And it put a name and a face and an experience that helps drive my advocacy. And so, yeah, I work for a big company and all that. But, I get up every day and I advocate for innovation. I advocate for simpler, more straightforward systems. And I do that because at the end of the day, it's about the patient. It's about giving them hope. It's about giving them an opportunity. And I feel like the harder we work, the more likelihood we'll be able to make good on that hope and that promise.
We have a couple questions for Peter Maag. In the realm of public policy, AAKP believes the entrepreneur, the person in the arena with the courage and capital to take risk and to bring new discoveries to the commercial market for patient consumers, is unprecedented. Can you tell us, as the CEO of one of the world's top medical diagnostic companies, your observations on the important role kidney patients and AAKP have in helping education policymakers on the need for policies that support more private sector innovation and entrepreneurs?
Well, thank you so much for this very important question. I feel humbled to be asked that question. I've been working in healthcare all my life, and I've been really thinking about what can we do, what can the community do to support innovation and driving the field forward, especially on kidney health, which is such incredibly important because it does impact so many patients in the United States and actually worldwide. Now, what can one do? I think we need policies that drive the right incentives, that are providing incentives for companies like CareDx to innovate and bring new solutions to patients. I think the Kidney Health Initiative is a great start, where we're really combining many different parts from policymakers, industry, and also other thought partners in driving the field forward. So setting the right incentives is incredibly important. Now, when I mean incentives, it's also clear incentives regarding reimbursement levels. Because ultimately, as a responsible company, we'll be investing into activities that allow us to provide our services to patients. And ultimately, that should be rewarded by strong reimbursement policies by Medicare. AAKP has been incredibly helpful in driving this field forward and also lobbying on new reimbursement policies that allows companies like us to provide our solutions going forward. Thank you so much for this question.
Okay, we have another question for you. As a corporate executive and as a person, you are known for your sincere empathy for patients and for your impatience towards policy barrier that exacerbate health disparities and prolong outdated medical treatment. Can you tell us how many personal relationships you have developed with kidney patients have impacted you and your determination to help deliver better care choices to them?
Well, thank you very much. I start my day asking myself, how many patients have we cared for yesterday? And then actually around 7 o'clock in the morning, I get the latest number for how many patients have we cared for yesterday. And I have a clear patient picture in my mind. It's very important and dear to my heart to support patients. It's who I am. Now, it is important in these strategies to think about what can one do and how can one navigate these very difficult situations. Now, when Corona hit, what did we do? We jumped and brought everybody together, and that's an example for patient centricity, is we brought everybody together and said, how can we service the transplant community that because they are extremely vulnerable of their immune suppression, they're actually at an even higher risk by catching a coronavirus infection. So we came up with a system that brings the mobile phlebotomist to the home. So you can get your diagnostic testing done in the safe environment of your home. You don't have to leave your home. You don't have to go to a transplant center. You get the services from the convenient place of your home. And this is something that we're very proud of because it exemplifies how we at CareDx think about serving patients. And I'm pretty proud of what we have done in the last few weeks while providing that service to many transplant patients across the United States. There are more than 4,000 patients that within that very short period of time have signed up for RemoTrack, our service. So that exemplifies how we're thinking about supporting the transplant community and being patient-centric. Thank you so much for your question.
We appreciate these panelists taking the time out of their schedule to share with us insights on upcoming innovations that can improve patients' lives in today's society.